Hello, and welcome to this week's episode of Population Health Nursing. This week, we're going to be covering community assessments. So, again, this week, we're going to be talking about just a community assessment, how you can collect data, the windshield survey, and then just developing education programs. Your assignments this week. So, your weekly questions are due at the start of class. We're going to do something for class participation. And then you have your web search assignment that is going to be due Sunday evening. This is on your chosen population where you're just going to go and look online and come up with, I think it's 5 resources about your chosen population. Tell me about them and put it in a Word document and submit it. Here are your weekly objectives. So if you remember from last week, the biggest concern of the community health nurses is we want to improve the health of the community. Therefore, we're always looking at ways that we can improve the community, we can improve the health of the community. And one way that we do that is through a community assessment. So whenever we start this community assessment, we have to look at a number of different things. So the first thing that we have to look at is a thing called an aggregate. And an aggregate is a community composed of people who have a common characteristics. So, they might live in the same city, they might be members of a certain group, like the YMCA. They might have the same religion or belong to the same religious organization. Examples could be like a student, a retiree, senior citizens, adolescents, nurses. So we have to look at the aggregates in the community. There is also this thing called a community of solution. And this is a community of solution can form when there's a common problem that unites individuals. So, maybe there is a problem where there is lack of like playground equipment. And there's a high volume of kids in a neighborhood. So the problem of not having this playground equipment can unite people. They might not have anything else in common, but the problem kind of brings them together. We look at the location of the community, and this is the actual shared features or, the geographic features or the physical boundaries of a specific area. These boundaries can demarcate the peripheries of cities, counties, states, nations, also can define like voting precincts, school districts, water districts, fire and police protection. And sometimes, you can see the physical boundaries, but other times there's less visible boundaries. And then we have to look at the social system. So, community members, they fulfill a lot of different roles in the community, but we have to look at, the essential functions of the community and how they interact. What's the socialization like? What's the goal? The member support. A community, it's very complex. It's a very complex social system. And we kind of have to see how that social system interacts with each other's. There are subsystems that interrelate and interdependent systems that can also affect that social system. So whenever we are um, completing a community assessment, this is kind of the steps that we take. The first thing is to just define that community. And then we're going to collect data, and we're going to talk about how you collect data next. We can analyze data, meaning like organizing it, reviewing it. There's different steps to actually analyzing data, like, we collect it first. We can assess the completeness of the data. We can identify anything that's missing, identify any themes, identify community needs and problems, and we can even identify strengths and resources that the community has. We're going to establish a community diagnosis, something like, like a food desert, a high incidence of heart disease, a lack of recreational activities. And then we're going to start to come up with like a program plan of how we can go about fixing our community diagnoses. Whenever we come up with that program plan, we also need to consider, funding for that program. Our sixth step is, actually implementing it, putting our actions into play. And then our final step of this is evaluating. We want to evaluate, did we kind of help fix our diagnoses? So when we're collecting data, it's best to kind of combine several different methods. We want to make sure that we get a good representative sample of the actual community. So there's a number of different ways that we can, collect our data. First being individual interviews. This is usually direct discussion with community members of the purpose of obtaining ideas and opinions from them. Um, the one good thing about this is it's low cost, so there's minimal cost. Participants can serve as future support. They can typically offer insight into beliefs and attitudes of the community. These individuals don't have to read or write anything, and they're personal, so they can typically have a more detailed response. However, whenever you are conducting an individual interview, there is a built-in bias. They might have an agenda that they want to fulfill. And also with these, you have to come up with a meeting time and place. It should be like a neutral area because, again, if we are trying to stay away from that built-in bias, it needs to be someplace that's kind of like Switzerland. It's a neutral party. We have community forums and open public meetings. If you look in the picture on this slide, I used an image from one of my favorite shows, Gilmore Girls, where they had town meetings. This is an opportunity for a lot of community input, but it is at minimal cost. However, when we think of these community forums, they can be inconvenient to people because of the time and place. People might not be able to attend because of things like work schedule or, their kids' activity schedule. This can have the potential to drive from the issue um, and can drive the actual issue. However, not everyone in that open forum will participate. People might be reluctant to speak. So it's not always the best way to get that representative sample. We can do observations, which are formal or informal community activities. This is probably one of my favorite things to do. It's simply people watching. Where with this can indicate of community's priorities, the environmental profile, identification of power structures. The bias of the observation is it is very time consuming. And also, you can't ask any questions. So you are just simply going on what you are seeing. Focus groups, very similar to that of like an open forum, but this is directly talking with a representative sample. So for instance, like your student advisory board, where you all choose people to sit on the student advisory board, and they are your representative sample of your cohort. With this, possible participants being supported, they can offer some insight into the community. However, with these focus groups, they can go off on a tangent. It might be challenging to get participants to actually participate. Whenever you have these focus groups, you need a strong facilitator because, again, you can go off on a tangent very easily. And this may not always be an accurate representation of the community. And for someone who is transcribing this focus group, it can be very taxing and very time consuming to actually transcribe the discussion. Surveys. So we can do these, kind of pen and paper. We can also do these online, where surveys are going to ask specific questions in a written format. This data collection, we can look at client population and some problems. It can be random sampling. Again, it can be written or online. and there is no contract, no contact is required with doing this. However, surveys typically have like a low response rate. Think of your idea evaluations that you guys do at the end of the semester. Um, we typically see anywhere on average between 10 and 20% of students actually responding to those surveys. They can be expensive. So, again, those idea evaluations do cost the college a good bit of money each year, and they're time consuming. Um, we're also collecting very superficial data, and the participants also need to be able to read and write. And if you remember back from research this past spring semester, you need to be asking questions that aren't going to kind of indicate a bias. You have to ask questions that you want to hear answers that you may or may not like. And then we can also use secondary data sets. This is the use of existing data like demographics, meeting minutes, health surveys. We can use credible web information, and we can look at prior concerns and needs of the community. And these data sets are going to allow us to look at trends over time. However, this data may not be an accurate representation of what the community looks like right now. Also, kind of going through these data sets can be very time consuming. Another way of obtaining data is through a windshield survey. And a windshield survey is used to make an organization or organized observations of the area and its people. So this is a descriptive approach that assesses several community components by driving or walking through the actual area. Again, it's going to be a descriptive overview. Whenever you're doing this, if you are driving, you need a driver so you can actually visualize and document the community elements. This can be time consuming, and your results are based only on the visualization and does not include any inputs from any member of the community. This can really help you gain an understanding of the environmental layout. It can also help you locate possible areas of environmental concern through sight, sense, and sound. So we're going to look at the environmental layout. We're going to look to kind of see what the environment is like. We can look at geographic features, things like the boundaries of where is the community? What are the boundaries? Are they natural? Are they man-made? Is there trees? The location of agencies. Are there health services available? Do they have human-made environments like roads, employment, garbage, sanitation? What businesses are around? What industries are there? We can also look at the people. Who is there? What is their general appearance? What's their ethnicity? Are there pets? Is there any evidence of violence? Any evidence of substance abuse? We can look at the housing. We can look at the quality of homes, the age of the homes. Are they single family, multifamily, a lot of vacant homes, a lot of abandoned homes? And again, we can look at the social systems of, are there social services like hospitals, dentists, healthcare providers, parks, places of worship? Is there evidence of public transportation, grocery stores, public services like EMS, animal control, police, fire department? So whenever we are assessing the community parameters, these are kind of the things that we want to look at. The geography of the community, what the population is. So, we can look at ethnicity, age, gender, all of our demographics for our population. We can look at the environment, the industry, education, recreation. Are there parks around? Are there trails? How are the sidewalks? The religion of a community, communication. Do they have a radio station, a TV station, a newspaper? Do they have public transportation? The political organization? community development or planning? Do they have disaster programs? What's their health statistics like? Do they have social problems? Do they have health professionals? Do they have physicians? Do they have providers? And what community services are available? Do they have things like EMS, police, fire? Whenever we are looking at the health of communities, again, we need to assess the parameters. So, the physical environment, the education, safety and transportation, politics, their government, health and social services, communication, economics, recreation. Whenever we are looking at the health communities, we're looking at the ability to respond to changing dynamics, indicating productive community functioning. We want to really urge positive changes. We want to stress the interconnectedness between people and the public and private sectors to make change. And each community has its own unique perspective on health and healthiness. Another thing that we can use to kind of help us obtain some data is our census data. So the census data is really going to be conducted every 10 years. It's a massive survey of all American families, and it's going to help the nurse really look at the area and see how it's changed over time. So, we can look at metropolitan statisticals, we can look at suburban, we can look at urban statistics, and things that are just going to give us some more information about our population. We can also look at vital statistics to help us in our data collection. So, vital statistics, these are official registration records of things like births, deaths, marriages, divorces, adoptions. You can usually get these from places like the courthouse. They're compiled annually and they're reported by local and state agencies. Another place to kind of get health data is the National Center of Health Statistics, or the NCHS. This is going to give you local, regional, and state government reports, and it's going to look at the demographic information and provide more descriptive information about your population. So, our next stop on our community assessment is kind of conducting a needs assessment. So, after you have recorded your data and you kind of analyzed it, you're going to do this needs assessment to help understand the community's perspective. You can use all of your data, methods, and you're going to go into a 12 steps in the needs assessment. So, you've identified the aggregate, you've engaged in community in the planning and assessment, you've required information, you've obtained your data. You can develop questionnaires or interview questions. You can develop procedures for data collection. You can train your data collectors, arrange for the sample representation of the aggregate, conduct that needs assessment, tabulate and analyze data, identify needs suggested by the data, and develop an action plan. So after we have conducted our needs assessment, we're going to come up with that community health diagnosis. So this is the next step in the nursing process, and it's used to synthesize the assessment data and create the list of actual and potential problems to develop a community diagnosis. It typically has 4 components. We are going to identify the health problem or risk, the affected aggregate or community, the cause, and the evidence that will support the diagnoses. So, here's an example of it: increased risk of disability among elderly population related to poor infrastructure, as evidenced by dilapidated sidewalks. Problems identified by the assessment are often stated as a community health diagnosis. This diagnosis is going to incorporate information from the assessment, general nursing knowledge, evidence-based practice, and epidemiological concepts. Examples of health diagnoses could be risk of low birth weight, among pregnant adolescents in the South Side related to low income, lack of availability of nutritious food and tobacco use, as evidenced by lack of secure housing, food bank use, increased unemployment rates, and smoking. Whenever you are coming up with your community diagnosis, I want you to think about how you come up with a hypothesis when you're doing your clinical judgment model. You're kind of looking at all of the data, you're looking at subjective, objective data, and you're going to come up with a hypothesis. Well, you're going to do the same thing for the community, but your community is now your client. It's not just individual, it's looking at the entire community, not just one individual. We're going to look at all of these things, and we kind of have said these multiple times throughout this lesson. The geography, population, the environment, industry, education, recreation, religion, communication, transportation, the public organization, political organizations, community services, public services, disaster programs, social problems or social programs, excuse me, health manpower, community development, community services, and health professional organizations. So now that we have come up with our health diagnoses, now we're really going to be doing like a good deep assessment into our problem. Think about, you are going in on clinical and you go in and you do just a quick head to toe assessment on your client. And from that, you really want to, focus on the respiratory system. So kind of think about your data collection as that quick head to toe assessment. Now your assessment is more of your focused. You're focusing on the problem that is going on with your community. So some things that we can do are, meet with the group leaders of the aggregate to clarify the expectations. We can determine socio-demographic characteristics. We can do interviews with key informants. We want to consider both positive and negative factors in the assessment. We want to compare our aggregate or our community with the norm. We can research potential problems, identify health problems and needs, and we can prioritize the identified problems and needs to create an effective plan. Whenever we are doing this type of assessment, there's 4 needs that we need to assess. So our first is express needs, and that's the demand for services and the market behavior of the targeted population. So that's kind of, what you want. The normative needs, so this is lack or deficient or inadequacies of services determined by health professionals. So this isn't so much what you want, but what you actually need. You have the perceived needs, and this is the wants and desires expressed by the audience or your aggregate. So this is like, maybe it is realistic, maybe it is the express needs, but it's also what the people feel like they need. And then the relative needs, and this is the gap showing different health disparities. Whenever we're determining the priorities during our assessment, there's some things that we want to kind of take into consideration. So, the aggregate preference, what would they like? The number of individuals affected by the health problem. So, who all is being affected by our community diagnoses? The severity of the health problem, the availability of potential solutions, and practical considerations like skills, time, available resources. And whenever we're looking at this assessment, it's good to really use something like Maslow's levels of hierarchy. Kind of looking at what our basic needs are. We can look at the levels of prevention, so primary, secondary, tertiary, to really refine our priorities. Whenever we're doing this assessment, we really want to get the community involved. We're going to start our assessment within the people. We're going to start where the people are. And we can use the 5 spheres of empowerment. So interpersonal, this is personal empowerment. Intragroup, where we can get a group involved. Intergroup, which is the community. Interorganizational, which is the coalition building. And then political action. Once we have come up with our diagnoses and we have assessed our community, we're going to come up with our goals and our objectives. So, our goals, it's where we want to be, what our ultimate goal is. Our objectives are our steps that we need to get there. They need to be measurable, they need to be specific, and we need to be able to quantify them. We can use our acronym of SMART, so specific, measurable, achievable, relevant, and time bound. Next up is our intervention. And I honestly think this is the most fun part of being a nurse is, when we get to come up with our interventions, this is when you get to be creative. And I know nursing students typically struggle with this because it really requires you to think outside the box. So we're going to do a number of steps. So the first is our pre-planning, and this is just kind of brainstorming of, okay, what could I do? We've done our assessment, so we've collected data about the community. We've done our needs assessment. We've looked to see what resources are available, any potential funding. We can look at secondary health data. We've come up with our diagnoses. We can identify and prioritize the needs of the community. We can analyze data, work with the community to develop priorities and establish outcomes. And we can consider the following of things like community awareness, readiness to address the problem, fiscal resources, the severity of the problem, and the amount of time for resolution. Then we can really get into the planning, and this is to develop interventions to meet outcomes. We can determine possible solutions, look at goals, plan logically, who is going to assume responsibility for each intervention, assess personal need, and determine funding. In my experience, when we are doing this planning phase, we need clear, concise communication. And then we have our implementation phase, which is making it happen. We're going to initiate our interventions, we're going to monitor the interventions, and we're going to look at the community response. And then finally, we're going to evaluate it. We're going to see, were our interventions effective? What were the strengths of it? What were the weaknesses of it? We're going to look for adequacy, efficiency, and appropriateness, as well as the cost. We're going to share our findings, and we're going to be doing like ongoing evaluation, ongoing quality improvement. We always constantly need to be evaluating everything. So this is an important component of the success or the failure of a project. We can look at a participant's verbal or written feedback. We can reflect on the previous stage to determine the plan's strengths and weaknesses. And we can communicate follow-up recommendations. So we have the process evaluation, which is more of like our formal evaluation. Whereas our summative evaluation, this is kind of looking at our evaluation and our outcomes. Both forms of evaluation should include adequacy, efficiency, appropriateness, and cost analysis. So there are health planning models in public health, and one is the pre-seed, pro-seed model. And this model is going to provide structure for assessing the health and quality of life issues. So our first P is our predisposing factors, things like the knowledge, attitudes, behaviors, beliefs, and values before the intervention that affect willingness to change. The R is the reinforcing factors, and these are positive or negative effects of adopting new behaviors, like things like social support. And E is enabling factors, and these are the environment or the community of an individual that facilitates or presents obstacles to change. The proceed is going to include things like policy, regulatory organizations, and organizational constructs in education and environmental development. Another plan that we can use in public health planning is the patch model, and this is a health promotion. It's a process that enables the population to have more control over its own health. This model really encouraged the idea that health promotion is a process that enables the population to have more control over its health. And it's an essential element of the patch model is community participation. Another element that is used to develop comprehensive health strategies. The patch model also achieved this through mobilizing the community, collecting health data, selecting health priorities, developing a comprehensive intervention plan, and evaluating the process. Other health planning models include the APEX PH program, which that's the assessment protocol for excellence in public health. This was a voluntary process for organizational and community self-assessment, plan improvements, and contributing evaluation and reassessment. The big emphasis of this plan is a community self-assessment. There's also the MAP model. This is mobilization for action through planning and partnership. And within this model, it's going to mobilize the community, guide towards shared vision, conduct 4 assessments, which include community strengths, local health systems, health status, and forces of change within the population. There has been some legislation associated with health planning. So, for instance, the Hill-Burton Act. This addressed the need for better hospital access. This act provided federal aid to states and hospital facilities, where the state had to submit a plan documenting available resources and the needs assessment to qualify for hospital construction and modernization funds. The Hill-Burton Act caused the expenditure of vast sums of money and resulted in an increased number of beds, especially in general hospitals. We also have the regional medical programs, or the RMP. The RMP is intended to make the latest technology for diagnoses and treatment, like heart disease, cancer, strokes, available to community healthcare providers. And they did this through the establishment of a regional cooperative arrangements among like med schools, research institutions, and hospitals. The goal of these arrangements were to improve the health manpower and facilities and make sure that the intent was to avoid interfering with methods of financing, hospital administration, patient care, or professional practice. There's also the comprehensive planning, which this broadened the previous legislations that were associated with health planning. It combined partnerships for health amendments of 1967, and these amendments created the Partnership for Health Program, or PHP. The PHP provided federal grants to states to establish and administer a local agency program to enact local comprehensive healthcare planning. There is also the certification or certificate of need, or the CON, which this increased capital investments and budgetary pressures. State governments developed the idea of obtaining prior for governmental approval. There is the National Health Planning and Resource Development Act. This combined the strengths of the Hill-Burton Act, RMPs, and the Comprehensive Health Planning Program to forge a new system of single state and area-wide health planning. The goal of this act and purpose of the new law were to increase accessibility as well as acceptability, continuity, and quality of health services. Health planning legislation, it is heavily influenced by politics. We saw a lot of changes, like especially with the Reagan administration, where they encouraged competition within the healthcare system, followed by the Clinton administration, who they came up with a plan for healthcare reform, included mechanisms to revitalize planning at the national level, but they failed, and in 1994 gave planning back to states and local agencies. Fast forward to the 2000s, when we saw the advent of Obamacare, or the Affordable Care Act. What this Affordable Care Act was determined to do was to reduce premium costs for millions of working families and small businesses by providing a tax relief. They made affordable healthcare insurance available to more people. The law provides consumers with subsidized, or like that tax credit that lowers cost of household with incomes between 100 and 400% of the federal poverty level. They also expanded the Medicaid program to cover all adults with income below 138% of the federal poverty level. They also capped out-of-pocket expenses. They required preventative care to be fully covered without any out-of-pocket expense. And basically, prior to this, if someone had a pre-existing condition like diabetes, hypertension, they could be denied services. And with the Affordable Care Act, no pre-existing medical conditions were denied. The Affordable Care Act also supported a lot of innovative medical care delivery methods designed to lower the cost of healthcare. This act provided individuals, families, and small business owners to have more control over their healthcare. It reduced a lot of cost. It reduced what families were paying for their healthcare, like their out-of-pocket expenses, and really just gave the availability of healthcare to a lot of people who didn't have it before. When it comes to health program planning, the nurse needs to work collaboratively with healthcare planners to improve aggregate health. Again, remember the whole goal of community health is doing what is best for the most individuals. We want to fuse technology with knowledge of healthcare needs and skills. We can become directly involved in the planning process and engage in aggregate level projects. As a nurse, one of the most important things that you're going to do in your career is provide that education, that health teaching. And it is one of the most fundamental principles in nursing. A nurse, even in the most obscure position, must be a teacher of no mean order. So for all of you saying, oh, I could never teach, guess what? You're going to. Health education is any combination of learning experiences designed to predispose, enable, and then reinforce voluntary behavior conductive in health. And we can do this individually, we can do this in groups, and we can do this in communities. Our goal of health education in the community is we need to translate health knowledge into interventions for health enhancement, disease prevention, and chronic illness. We can enhance wellness and decrease disability. We can actualize the health potential of individuals, families, and communities in society. We can influence individuals with their socio-political environment for improved health and well-being. There are different cognitive and behavioral changes engaged learners to become partners in their own health. Learning is something that we never stop doing throughout our life. Learning, it's an enduring change that involves us modifying our insights, our behaviors, our perceptions, and our motivation. There's a lot of different learning theories, but we're going to look at the humanistic, the cognitive, and the social learning theory just briefly. Humanistic theories, these help individuals develop their potential in self-directing and holistic manners. Cognitive theorists recognize that the brain's ability to think, feel, learn, solve problems, and they train the brain to maximize these functions. And with social learning, these theories' premise is based on the idea that behavior explains and enhances learning through the concepts of efficacy, outcomes, expectations, and incentives. When we're doing community health, we have to think about the adult learners, and they typically learn better in a facilitative, non-restrictive, and non-structured environment. There are characteristics to that adult learner that can really affect their learning. And the first is their need to know. Adults must know why they need to learn. The nurse should explore reasons that the individual families and groups want to learn and identify their learning needs. The concept of self. So adults have a concept that develops from dependence to independence, and it moves from one direction to self-direction. And adults want to be capable of self-direction. The nurse should really acknowledge that individuals, families, and groups can make choices and decisions. And that nurse creates an environment in which patients can express themselves. We really want to be giving them that autonomy. And that, these individuals can learn from their selected actions and take self-direction and responsibility for their behaviors. We also have to think about their experience. Adults can draw on many life experiences. And those experiences can be very powerful learning resources. The nurse in this situation should look for life and worldview experiences related to health issues. The nurse can help facilitate connections between previous and past experiences and present experiences as well. The nurse allows for individuals to share their experiences with others in a supportive and trustworthy manner. The nurse should clarify previous and present experiences, and this is especially helpful with negative or positive past experiences that may impact their learning outcomes. We also have to look for the readiness of learn, um, in which, developmental tasks and social roles affect readiness to learn. The timing of the learning experience with the developmental task is very important. The nurse should be assessing, individuals, families, groups, for their key developmental tasks. So, kind of going back to Erickson's, going back to Piaget. The nurse finds out what matters to the individuals. They should seek to understand the impact that their roles and tasks have on learning. The nurse supports individuals, families, and groups to learn according to their social work or family roles, as well as their developmental age. And you really want to be having like a role modeling experience. And lastly, the orientation to learn. Learning is often presented and oriented and now based. Learning is directed to the immediate need, and it is the problem centered to immediate application of everyday life. The nurse should be assessing the learning needs of individuals. The nurse should recognize everyday stresses and hassles and address them within the learning context. And the information that the nurse gives um, is in response to their immediate needs. And lastly, we need to look at their motivation to learn. Their internal drivers, the factors that are motivating them, things like their self-esteem, their life quality, their life goals, their responsibilities. The nurse should determine the internal motivators. The nurse should assess for impediments that block motivation, things like poor self-esteem, lack of resources, and provide appropriate education, counseling, support, referrals to optimize motivation. So, in addition to the theories that we have on how people learn, we also have health education models on, kind of how we can teach things. These theories kind of help link the education theories into the principles and situations that they're facing, to help people understand like how ideas fit together. They can offer explanations and they can help to direct community nursing interventions. We have a number of different education models. The first is our health belief model, and this is based on a social psychology, and it has undergone a lot of testing to predict compliance on singular preventative measures. Initially, the health belief model was actually used to explain why people didn't participate in health education programs to prevent or detect disease, particularly with like tuberculosis. The health belief model is a value expectancy theory that addresses factors that promote health enhancing behavior. It is disease specific and focuses on avoidance orientation. It considers perceived susceptibility, perceived severity, and perceived benefits, as well as perceived barriers and cues to action and other socio-psychological and structure variables. Those are our modifying factors. Self-efficacy is defined as the notion that an individual can actually successfully on a given behavior to produce the desired outcome. We also have the model of health education empowerment, and this model suggests that nurses cannot assign power and control to the individual within the community, but rather the power must be taken on by the individual and community, with the nurse guiding this process. So this process can include examination of different factors like education, health literacy, gender, race, discrimination, social justice, class and recognition. Basically, the knowledge is produced in a social context and it is bound to relations of power. Therefore, an appropriate and more relevant health education model may be one that embraces the broader definition of health and addresses social, political, and economic aspects of health. We also have a focus on problem solving education. So, problem solving education allows active participation and ongoing dialogue and encourages learners to be critical of and reflective about health issues. Freire suggests that when an individual assumes the role, they often become powerless and allow the environment to control them. However, when individuals become subjects, they influence the environmental factors that affect their lives in the community. And then when they do this, they basically look at the best resources to elicit some type of change. We also have the participatory action research, which the goal of this research is social change. It is very consistent with the role and responsibility of nurses who are engaged in the community and community health, and embraces the use of community-based participatory methods. What this means is that the participation and action from stakeholders about the knowledge of conditions and issues help to facilitate strategies. Maybe looking at access to care, access to information. There is also the community empowerment. Community empowerment is a central tenet of community organization, where community members take on greater power to create change. It is based on the community culture, and an empowerment continuum acknowledges the value and interdependence of an individual and political action strategies aimed at the collective while maintaining the community organization as a central. The nurse's role in health education. So again, we're going to be doing a lot of educating throughout our entire careers. With community health, we are going to become a partner with the individuals in the community, and we're going to kind of be that catalyst, that drive for change. We can help activate ideas, we can offer appropriate interventions, help individuals and communities identify resources, and just really empower the group, empower the community. Community health nurses is a leadership role when coming up with health program planning. We need to look at what is the goal to improve the health of the community and how are we going to do this? We want to do a lot to promote, maintain, and restore health. Just some examples. We can do education through things like exercise classes, cooking classes, trainings. Community health nurse can be program planning to promote healthy communities. Community members can become partners to address issues. We can look at the relevance of the problem to the public, so the degree of the risk, the economic loss, the loss of lives, the severity of it. And we can also look at the estimated effect of intervention. How is it going to improve health outcomes? Are there any adverse effects associated with these interventions? We look at the framework for developing health communications. There's different frameworks that helps with health education messages and programs. This framework has 4 stages, and it's kind of a circular loop that offers the opportunity for continuous assessments, feedback, and improvement. So the first stage is our planning strategy selection, where we look at the foundation for communication program success. So in this stage, we're going to kind of think about the questions to ask. Who is our intended audience? What is known about the audience and from what sources? What are the communication and education objectives? What evaluation strategies are we going to use? What are the issues of most concern? What is the health issue of interest? From this is going to set the stage for creating good communication. It's going to allow us to review available data, get community partners involved, obtain new data, determine perceptions of health problems, determine the community's assets and strengths. help to identify underlying issues and knowledge gaps, and establish goals and objectives, and also look at resources that are available. In stage 2, we're going to be developing and pre-testing concepts, messages, and materials. So again, we're going to select our appropriate communication channels. So what questions should we ask? Well, what channels are best and what format should we use? Are there existing resources? How can the nurse present the message? How will the nurse intend the audience to react to the message? Will the audience understand and accept the message? And what change may improve the message? With this, we want to produce effective and relevant materials. So some actions we could take is just identifying the messages and material, decide whether to use existing materials or to, make new ones. Sometimes it never hurts to not reinvent the wheel. We want to develop relevant materials with the target audience, and we can pre-test the message and the materials and obtain audience feedback. In the third phase of the program, this is implementing the program. So we're going to introduce the health education message and the program to the intended audience. So again, we're going to ask some questions. How should we launch the program? How do we maintain interest and sustainability? How can we use process evaluation? What are the strengths of the program? How can we keep it on track within a timeline and a budget? How do we know if we've reached our intended audience? And how well did each step work? So this is with our process evaluation. And are we maintaining a good relationship with our partners? From these questions, we would be able to review and revise any necessary components. And this will allow us to work with community organizations to enhance the effectiveness of it, monitor and track progress, and establish process evaluation measures. In our final step, this is assessing effectiveness and making refinements. So this is our evaluation. We're going to evaluate our outcomes to determine whether or not changes or knowledge or behavior have occurred. So things we're going to ask is what was learned? How can outcome evaluation be used to assess effectiveness? What worked well? What didn't work well? Has anything changed about the intended audience? Do we need to change anything? Should we refine our methods, our channels, our formats? And overall, what lessons were learned and what modifications could strengthen the health education activity? From this too, we can also conduct outcome evaluations. We can keep reassessing and revising our goals and objectives. We want to modify unsuccessful strategies or activities. We can generate continual support from businesses, healthcare agencies, and other community groups for ongoing collaboration and partnerships. We can look at health education resources, and these are materials, media, resources that are available from local, state, and national organizations. So some examples could be like from our local and regional hospital. They could have libraries, clinics, adult education centers, health education centers, media outlets. There's local and governmental sources. There's community-based organization, university and colleges, community colleges, and academic nursing centers. There's also professional organization, commercial organization, federal government sources, voluntary agencies and their affiliates, internet searches, and Medline Plus health information. When we're conducting health education, we must take into account health literacy. We have the National Literacy Act of 1991 that literacy is an operationally defined as the ability to read and write at the 5th grade reading level in any language and can be measured according to a continuum. This definition is consistent with the Healthy People 2020, that the capacity to obtain and interpret and understand basic health information and services, and the competence to use such information and services to enhance health. Sometimes, especially as a healthcare professional, we tend to mismatch reading levels and the materials that the patient's reading skills are at. Whenever we are providing something that needs to be written, or even as we are talking about something, we need to make sure that our patients can understand it. If a person has low literacy, it's going to prevent them from gaining the full benefits of their healthcare because they do not understand what they're reading and not able to comprehend what we're saying. Not everyone is going to be able to, read an article and understand what the article is saying in regards to their health. But we have to include health literacy because this is going to increase community members' ability to successfully manage their everyday situation. When people understand things about their health, it's going to empower them about having access to the information. They're going to have better knowledge of it. They're going to understand innovations. It's going to help them just increasingly important for social, economic, and health development, and it is a key public health issue in the delivery of safe, effective care. There's three interventions or three levels of interventions that an individual and population benefits. So, functional basic literacy, being able to read and write, communicative and interactive literacy, and critical literacy. When individuals don't have good health literacy or low literacy, it can cause a lot of, negative health outcomes. It can decrease the utilization and access to healthcare services and increase cost. It can decrease their self-esteem, increases shame, and increases stigma. We can see a lot of adverse effects with things like diabetes, cancer screenings, medications, HPV, blood pressure control, dialysis maintenance, cervical cancer, smoking, dental health, and the use of patient portals. It can pose barriers to obtaining informed consent. It can affect participation in research. It can pose barriers to, again, obtaining informed consent just because they don't understand things. And the number of questions asked at medical visits because, people might um, feel shamed that they don't understand what they're talking about. They might not want to ask questions. So, whenever you are teaching a patient, whether it's in community or it's in the clinical, it's on a med surg unit, in the ER, the OB unit, wherever. First thing that we need to kind of do is read the audience. We want to assess their reading skills, determine what the client needs to know, also determine what they already know, what their motivating factors are. We want to stick with the essentials, stick with the basics, keep it simple. We want to set realistic goals and objectives, use clear and concise communication, clear and concise language. I always like to use big words because it makes me sound really smart, but really, I am just a simple person. We want to space teaching out over time. Like, you don't want to jam pack all of this information into one short session. They're not going to grab it. Personalize the health message. Have it relate to something that is important to them. Incorporate methods of illustration, demonstration, and real life examples. We want to give and get. So anytime that we're educating, it is best for them to provide a teach back. We want to summarize often of what they should have known or should have been taught. Be creative with your teaching approaches. You guys know how I am. I like to draw pictures, even though they make no sense. I use a lightsaber to illustrate Hirschsprung's disease. So just kind of be creative. Again, relate it to something that they're going to understand. You want to use appropriate resources and materials. Any education that you provide to a patient should be no more than a 5th grade education level. That's important to know. It should be simple. People should be able to understand it. You want to praise patients. You want to encourage them. Allow them to ask questions. Allow that comprehension and understanding do take some time and practice. I want you to think of yourself as the nursing student right now. Sometimes, like, think back when you were first learning ABGs and fluid electrolytes and all of that fun stuff. That first time through, it didn't always click. But as you started doing it more and you started to kind of read through it and ask questions, then you got that information. So be patient. Conduct that learner verification. Again, that's that teach back, and evaluate your teaching plan. We need to actually review any materials that we give to a patient. We should evaluate the health materials, including websites, pamphlets, videos. We should review them before we actually teach them to someone else. Any material that we give them should strengthen previous teaching. Please never go into a room and hand your patient a pamphlet and go, there you go, just read about that. It'll tell you everything. Materials should be used as an adjunct to health instruction. You need to physically sit down and teach your patient, teach your community what your objectives are. It should be appropriate for the intended audience in the community, and also be appropriate for education initiatives. Again, we want to assess the readability of educational resources. So there are different formulas like the SMOG readability formula, the Flesch-Kincaid formula, which is on most computers. And you can just search readability statistics of like an article, of a video, just to verify what, you know, how someone would read it. Is it at that fifth grade level? Lastly, that learner verification is so important. Anytime that you are educating a patient, a client, one, you actually have to do the education. You want to provide them good education. You want them to do that teach back. That is their learner verification. And you always want to document that patient or client was able to provide return demonstration of. The learner verification engages the intended members in dialogue and helps to uncover suitable or unsuitable aspects of the material. So maybe they didn't understand something. This process helps identify that the message is well suited to the audience, that they understood it, that they were able to take in, they were able to understand the point that you were teaching and be able to apply that information. One of the ways that we can get mass amounts of education out to a community is through the use of social media. Now, social media can be a lot controversial. Not everything on social media is always like credible. And we have to be aware of that. That is why we need to evaluate our resources before we start to tell our patients, our clients, yeah, go on TikTok and look up this person or look at this video. We need to make sure it is credible information. There's lots of platforms that are available with blogs where people will type out things. There's online discussion boards like Reddit. But again, you have to make sure that they are credible. You have microblogs like Twitter. There's video sharing with like YouTube, TikTok. With social media, it can reach a lot of diverse community constituents with important public health messages. It has the potential to facilitate interactive communication, increase sharing of health information, and personalize health messages that will reinforce the education that you're teaching. Social media can really empower a lot of the community to help them make informed decisions about their healthcare. If you have any questions, please let me know.